Thank you. Well, it's great to be here. I'm happy to be back in Bowell presenting. Like Eric said, I did my fellowship here, and it's always great to be around mentors and colleagues and to share a little bit. This morning, we'll talk a little bit about sleep disorder breathing in patients with neuromuscular disease. I have no disclosures. And our learning objectives for today will be to describe the indications for initiating ventilation in patients with neuromuscular weakness, to delineate the different modes of ventilation available, and then to identify strategies to troubleshoot common ventilatory problems that may come up with non-invasive ventilation. And before we start with the question, I'll just put a apology out there for my neurology colleagues. I'm sure when they see my title, neuromuscular disease, that's like a catch-all term that, is not nuanced, but you'll see that we'll go through some of the individual neuromuscular entities. And really, I think we think about this from a sleep and pulmonology standpoint as how it affects the lungs, generally speaking, right? Because there can be different effects, and we'll go through it, but generally we think of neuromuscular weakness, inability to fully expand the lungs, restrictive lung disease, or restrictive lung mechanics. So we'll start off, and I'll ask one of the fellows to volunteer an answer, but I'll read the question out loud. So a 12-year-old boy with Duchenne's muscular dystrophy and a body mass index of 35 underwent a diagnostic polysomnography due to symptoms of excessive daytime sleepiness and morning headaches. The results of the sleep study show an AHI of 5 events per hour. SpO2 was less than 88% for 10 minutes, which was 3% of sleep time. The end-tidal CO2 was above 50 millimeters of mercury for 3% of sleep time. So what is the next best step in management? A, watchful waiting with outpatient follow-up in 6 months. B, initiation of nocturnal non-invasive ventilation. C, recommend weight loss. D, initiation of nocturnal supplemental oxygen. Or E, initiation of intranasal corticosteroid therapy. Anyone want to venture a guess?
He can definitely lose weight, but I'm not sure that would be the next step.
Very good. So you just took your board, so that's what they're asking. The next best step. So there are a number of options that are good, but which one is the best for this case?
Are you able to move back to the previous slide?
Yep. So Duchenne's BMI is 35, HI 5, less than 10 minutes of SpO2 below 88%, and his end-tidal is 50 millimeters of mercury for 3%.
I think we need a little bit more information about the distribution of the hypoxia and the ventilation. Is it occurring during respiratory events, or is it independent of?
It's during respiratory events.
Start CPAP.
Okay.
I recommend weight loss.
B, non-invasive ventilation. That's actually the correct answer. The other ones are, so A, watchful waiting, that's not correct, right? That's more for, this comes from the chat study with children with mild AHI range where you can wait 6 months. C, recommend weight loss. That would be in someone who has OSA but without neuromuscular weakness. D, nocturnal supplemental oxygen. The issue here is hypoventilation. Supplemental oxygen wouldn't help the hypoventilation. And the initiation of intranasal corticosteroid. Again, that would be for someone with nasal obstruction, but no neuromuscular weakness. So when we think about why that is in neuromuscular impairment, what's the respiratory impairment? We think about respiratory failure. And because respiratory failure is important, it's the most common cause of mortality in neuromuscular disease. That's why pulmonology and sleep is an integral part of the care of the patient with neuromuscular disease. And so when we think about what causes the respiratory failure, you can think about the respiratory system as a respiratory pump, broadly speaking. So the respiratory pump dysfunctions, there's dysfunction of the respiratory pump, which leads to hypercapnic respiratory failure, right? Hypoventilation, the CO2 is high, which can lead to downstream effects, which we'll talk about. And then there's also parenchymal lung disease that develops as a result of weakness, not being able to clear secretions, recurrent pneumonias, those types of things. And so on the left-hand side, we have the respiratory pump, the components of the respiratory pump, which include the chest and abdominal wall, and the cause of the failure of the pump. So for chest and abdominal wall, that could be mechanical disorders of the chest, and abdominal wall. You think about someone with a small chest, you think about someone with neuromuscular scoliosis, respiratory muscles. If there's respiratory muscles fatigue, then that pump is going to fail. And respiratory control center, if there's depression of the respiratory control center, it's not responding to elevated CO2 properly. You're talking about the central control of breathing, the central chemoreceptors, then that's going to cause respiratory failure. And all these are issues in neuromuscular disease. And so to just go into a little bit more detail, if the pump is overloaded, there's too much load on the pump will fail. So when we think about it in its other terms, we talked about muscles, but what about chest wall compliance? So children with neuromuscular weakness, the chest wall compliance is high. Well, in general, in young children, the chest wall is high, which means that the chest wall can deform during tidal breathing due to the negative intrapleural pressure. They have inefficient breathing because they don't have the normal, like we think about in adults, where the chest wall wants to spring out and stent and counteract the lungs' tendency to collapse. So having a stiffer chest wall in the normal range is helpful to keep those lungs open. And so having a overly compliant chest wall leads to inefficient breathing, and that increases the work of breathing. In terms of adults, so adults with neuromuscular disease, their chest wall is less compliant, so they have the opposite problem. Their wall is stiff, the chest wall is stiff, and then it's an increased load against which the respiratory pump has to work to expand that stiff chest wall. You think about abdominal wall compliance. So if you have increased compliance, then that limits the effectiveness of the diaphragm. Again, when you breathe, the diaphragm pushes the intra-abdominal contents that are living in the thorax, bottom of the thorax, down into the abdomen, and then that you'll have abdominal excursion, which you see on normal breathing, but to a point. But if you have a weak ventral wall, then that increased compliance that limits the effectiveness of the diaphragm. A diaphragm, if that's weak, that's a major muscle respiration during wakefulness and sleep. And then obviously if there's chest wall or spinal vertebral column issues like in neuromuscular scoliosis, that will restrict that will cause a restrictive pattern. So why does nocturnal hypoventilation happen, or sleep, let's say sleep related really, hypoventilation happen? So in neuromuscular weakness, you can have diaphragmatic weakness. Further, you have drops in lung volume during supine and then during sleep as well, where your FRC, your functional residual capacity, is decreased. You decrease ventilatory response to hypercapnia. That's what we talked about, the central receptors, where you have a buffering effect for those hydrogen ions, CSF, by bicarb. So that actually reduces the response to increased CO2. You can have anatomic or neurologic upper airway obstruction. You see that very much often in Duchenne's. That's sort of the first kind of respiratory issues in sleep, is actually the upper airway obstruction. And then other issues that come along with the neuromuscular disease like heart. Mute themselves. Someone's on not on mute. Thank you. So initially these issues happen during REM sleep because during REM you have decreased activity of the intercostal muscles, and then it progresses as muscle weakness progresses to non-REM sleep. And so here's a little schematic of what we talked about in neuromuscular weakness. During REM sleep, you have an increase of the arterial CO2 and decrease in the arterial partial pressure of arterial O2. So hypercapnia and hypoxemia, or this results in desaturation. They have interrupted sleep, so frequent arousals. They have decreased sleep efficiency. Sleep deprivation leads to increased alveolar hyperventilation. They have bicarb retention, depression of respiratory drive, meaning this is due again to the buffering in the central chemoreceptor. So that's not what you would see in the ABG per se in arterial blood gas, but more how the central chemoreceptor decreases its response to increase in CO2 or increase in hydrogen ions. And then it progresses to severe nocturnal hypoventilation and diurnal hypoventilation. For those who don't know, like I didn't know, diurnal means daytime. So it progresses to nighttime and daytime. So both asleep and awake hypoventilation. And so in other words, if you think about it in this sort of a simpler scheme, in neuromuscular weakness, you can have inspiratory muscle weakness, expiratory muscle weakness, and bulbar muscle weakness. Leads to sleep disorder breathing and abnormal gas exchange, leads to daytime symptoms, leads to abnormal gas exchange while awake, which leads to daytime respiratory failure and failure of the respiratory pump. And like we said, respiratory failure is the most common cause of mortality in patients with neuromuscular disease. So when do you initiate non-invasive ventilation? Right here. So when you have a patient who has sleep disorder breathing or symptoms of sleep disorder breathing, that's when you initiate assisted ventilation. And we'll go through some of the studies that talk about why that is. But this is very important. When you have a patient with weakness, you know that symptoms are very subtle. So you have to be a sleuth about this one and have a high index of suspicion, because they might not have the normal answers to the normal questions of sleep disorder breathing. You know, do you snore or gasp? Pauses in your breathing at night. They might say, no, my child never snores. And that might be because they're too weak to cause, to have an inspiratory flow turbulence that causes snoring. So the prevalence is very high of sleep disorder breathing in this population, over 40%. And so if they don't have the classic symptoms of snoring, so what are you going to ask when they come to your clinic? When you see a patient with neuromuscular disease in sleep clinic, so you're going to ask them this, and I ask my patients this every single time, because this is the questions that are going to make it or break it. Is your child or are you fatigued? Do you have dyspnea? I mean, are you out of breath? Do you have morning headaches or continuous headaches? Are you sleepy during the day? Do you have difficulty concentrating? And so you use age-appropriate things, right? In children, you say, well, how are you doing in school? Are there any concentration issues in school? Are there any attention issues in school? Are you falling asleep in class? Are you having a headache in the morning? Nighttime symptoms are pretty similar to our other populations, but it might be more that they're waking up, like they interrupted sleep, they have decreased sleep efficiency. So they have frequent nocturnal awakenings, they're hard to get up in the morning. Tachycardia is another symptom. Growth and development, and this is probably more pertinent to children. Are they having decrease in growth development? How are they developmentally progressing? And then pulmonary function, we'll talk a little bit about this because this can be predictive of nocturnal hypoventilation, but do they have abnormalities on pulmonary function tests, which we'll talk about? Do they have abnormalities on lab tests? So obviously, if they're hypercaffeinated, they have high CO2 on their arterial blood gas or other ways of measuring CO2. They have polycythemia to make up for chronic hypoxemia, and obviously that can lead to cor pulmonale and heart failure. And some patients might be asymptomatic, importantly, despite that they have hypoventilation. So all these considerations, if you think about these, like this is how the patient presents. They can present with the classic symptoms, they can present with non-classic symptoms, or they can present with no symptoms. So how do you go about figuring out when to do diagnostic testing or not? So before we go into that, I just want to, yeah. You
said that 40% have sleep disorder breathing. That must be a cross section, because if you have a progressive, you'll eventually get to some point.
Yes.
So that's really an underestimate. That's a conservative estimate.
Yes, I would agree with that. Yeah.
And I don't know if people have looked at the progression over time. We got a chance to look at that.
Yeah.
The second was the idea of dyspnea and growth and development changes during wakefulness, right? Dyspnea during wakefulness, is that correlated with their wakefulness pulmonary function, or is it correlated merely because of the sleep disorder breathing? I mean, we hear about that in adult run-of-the-mill sleep apnea, that dyspnea is part of it, but we really haven't paid attention to why that is.
Yeah, that's a good question. So what Kingman asked was this: the dyspnea during wake, is that, if I understood the question correctly, is that related to OSA like it is in adults, or is that something else? And I don't know the answer to that. I think when I read the literature, I understood it to mean that that's a sign that you have respiratory weakness of the respiratory pump. And so,
when you're awake.
yeah, when you're awake, and
therefore
therefore,
you get it.
right, and therefore you can extrapolate that if you have weakness while you're awake, that's going to be worse while you're asleep. But that's a great question.
I know why too.
Yeah.
Everybody has said it since 2004.
Right. Yeah, but that's a great question to see if that's related to, OSA. So when we look at, types of neuromuscular weakness, it's really very varied, right? You have obviously neurology. The first question they teach you to ask is, where's the lesion, right? Like you're not going to get through a third-year medical school rotation in neurology without knowing that question. And so when you think about it, if you look at the left-hand side, etiologic sites, so you can divide it up into spinal cord, motor neuron, motor nerves, and then the muscle, and then even enzymes like in Pompe or glycogen storage disease type 2. And so based on where the site of the disease is, that will affect its clinical course, and then that will obviously affect its predominant disorder, sleep disorder breathing event, and they'll have varied mechanisms. So we don't have time to go through each one in detail, but just know that there is nuance to the term neuromuscular disease. Now, with that being said, what are some predictors of sleep disorder breathing other than the history? So people have looked at pulmonary function tests as prognosis for need for mechanical ventilation, but also as a predictor for sleep disorder breathing. And so the forced vital capacity is a measure that's easily attained by spirometry. To notice that if someone has a true restrictive lung disease, you'd have to do something like plethysmography or a helium dilution, so a little bit more of an advanced test to diagnose an actual restriction. But the FVC, or the forced vital capacity, is something that's easily done in really any office. And so in some neuromuscular diseases, there's a predictable pattern. So like Duchenne's muscular disease, once they start in the non-ambulatory phase, their functional vital capacity, that is how much you measure it after you take a full inspiration, and then you blow out all your air down to where you can't blow out anymore, right? So that is that amount of volume of air that you're able to blow out, that declines over time in a predictable manner in Duchenne's, for instance. There are also fractional lung volumes, which we'll look a little bit more on the next page. But if someone say like an ALS, for instance, they'll have more of a residual volume amount of air that they can't blow out, even if they're trying to blow out all the way, as opposed to someone who, let's say, has a spinal muscular atrophy with a small chest and they're very weak. Their total lung volumes, the amount of air that they get in their lungs, will be decreased compared to a child or an adult at their age. So it'll be overall decreased. And then there are ways of measuring strength of the diaphragm or expiratory, inspiratory muscles by having them things called maximal inspiratory pressure and maximal expiratory pressure and sniff tests. So these are all tests that are available in the pulmonary function lab. So here's an example of lung volumes in ALS. Again, this is not the pattern in every neuromuscular disease, but in ALS, you have our different volumes. So from bottom, let's go from top to bottom. You have your inspiratory reserve volume, your tidal volume, your expiratory reserve volume, and your residual volume. And so this is in a normal, and on the left is liters, and on the y-axis is liters, starting at 0 and going up higher. And so this is what a normal person without adult looks like. And so in ALS, you have actually higher residual volume. So the vital capacity is decreased. The TLC, the total lung capacity, I mean, how much air you have on full inspiration, is not dramatically decreased, but the vital capacity is decreased because there's this amount of air, the residual volume, that they can't blow out. When they're supine, their lung function, their vital capacity decreases even further. And when they're asleep, their vital capacity decreases even further. Like I said, in other entities like spinal muscular atrophy, they'll have a reduced TLC, right? So it's going to look different, but this is used as a predictor. Studies have used this as a predictor, mean that forced vital capacity as a predictor for when to start non-invasive ventilation on patients with ALS, for instance, okay? And so here's, for instance, this is not an ALS, but this is sort of an all-comers on primary myopathies. This is a study of 42 patients. They looked at predicted thresholds to determine different degrees of nocturnal hypoventilation. And what they found was that if your inspiratory vital capacity was less than 60 and your MIP was less than 45, then that would lead to hypoventilation confined to REM sleep. If the vital capacity was less than 40, then it's continuous hypoventilation. And then a vital capacity less than 25, then you'd have diurnal or daytime respiratory failure. Now, what is the rationale? There are studies from ALS. I didn't put them in because I didn't think we have time to go through all of them. But if you have questions about that, I'd be happy to talk to that. So what's the rationale for starting assisted ventilation? And the upshot of those ALS studies, there are different ones, one from 2018, which is retrospective, and one from 2021, which is prospective. But basically, you have increased 3-year survival the earlier you start non-invasive ventilation. One study looked at starting it at FVC of 80%, one looked at it at 65%, comparing patients with above and below that threshold. So the rationale for assisted ventilation is it leads to improved survival. It treats the nocturnal and daytime hypoventilation, reduces morbidity, so reduces frequency of admissions for pulmonary infections. And then in the young children, we talked about how the chest wall is compliant and then it gets stiff over time. So there's a theoretical prevention of the chest wall deformity of those, because the chest wall is made up of muscles and bones and joints, and those things can stiffen. So if you allow those to expand all the way, the goal is to avoid contractures and a normal chest wall shape. Now, when do you start non-invasive ventilation? Well, it depends which guideline you read, right? So here you have in children, you have the British Thoracic Society has their, you have disease-specific, so Duchenne, spinal muscular atrophy has their guidelines, Duchenne's has their guidelines, and they're all different. I'm not going to go through each one, but I'll just show you the Duchenne's that Dr. Bernkrant was the lead author on from 2018. So here they recommend a sleep study with capnography yearly. And then they also they have recommendations about when to start nocturnal assisted ventilation. And in a different slide, I'll show you in bigger print what those are. So first of all, what is the role of the PSG? Now, I will tell you as an aside that there are some pulmonologists and maybe neurologists who handle the non-invasive ventilation part for these patients that do not advocate for PSG. So it's an important question. What does the PSG add that you couldn't get otherwise, right? What diagnostic value does it have? And if someone's monitoring the chat and wants to, stop me if there are questions, please let me know.
Question.
So, yeah.
So Dr. Pato has a question on how reliable are MIPS and MEPS compared to measuring PDI. And are we able to measure that in the PFT labs here? I think that was pertaining to the slides, probably 2 slides ago.
Measuring PDI?
Yeah.
Oh.
Difference for the diaphragmatic.
Yeah, that's a great question. I don't know the answer to that question. I'll have to look into that. I don't know.
So, MIPS and MEPS are historically the easiest to do because lots of labs do it. And transdiaphragmatic pressure is not performed, and it's not performed. Really, it could be for looking at isolated diaphragm paralysis, would be where it has its specific role, in which we see about 1 patient every year.
Mm-hmm. Do they do that in the adult lab, PDI? No? Okay.
The other thing, this is Christy, the other thing I would add to that is that MIPS and MEPS are really portable, so it's easy for us. We see a lot of patients out in the community, and it's easy to bring the equipment and do it, out in any clinic that we go to. So that confers an advantage, at least in pediatrics.
Any other question in the chat?
Thank you. Let's see the chat. No, there's nothing else. All right. So what advantage or what can we gain from a PSG? So it can identify early nocturnal respiratory impairments, obviously the normal things, apnea, hypoventilation, hypoxemia, but early, right? So that's if it's only during REM sleep. You get a sense of early warning of respiratory muscle involvements, and we'll show some examples of what that will look like using the respiratory ductus plethysmography bands and flow signals. And then this is sort of a caveat, and you'll see that the group is advocating for that. Many groups are advocating for this. When we talk about the criteria for getting a non-invasive ventilation, like a BiPAP or a respiratory assist device approved, some patients need, we know, or the data, the accrual of the data over the last maybe decade has indicated that it's helpful, or early intervention is helpful. And we'll talk about the CMS, Centers for Medicare, Medicaid and Medicare Centers guidelines, which are really based on the late 90s. And so you might not get a patient qualified based on their lung function, but you might be able to get them qualified based on their sleep study. So that's sort of like a workaround with the system that we have in place, meaning working with the limitations of insurance and things like that. And as we talked about, it can allow for early intervention, which can lead to improved quality of life and survival. So here's just an example from the Duchenne guidelines. They recommend non-ambulatory individuals with symptoms of sleep disordered breathing should have sleep studies as often as annually, if possible. So what does it mean, symptoms of sleep disordered breathing? Those are the things that we talked about earlier. You asked those questions. Is your child tired during the day? Are they having morning headaches? Are they having difficulty concentrating? Obviously, if they're snoring or having apneas, then you're going to get a sleep study. And this is it as an example, the Duchenne's guidelines. They say here, I have it over here. Again, this is just the Duchenne specific guidelines. They recommend to initiate non-invasive ventilation if your functional forced vital capacity is less than 50% predicted. If you have maximal inspiratory pressure less than 60, awake baseline SpO2 is less than 95, awake baseline PCO2 on a blood gas or transcutaneous is over 45 millimeters of mercury, and then if you have sleep hypoventilation, sleep disorder breathing, or abnormal sleep study, like an AHI of 5, I believe it is. Yeah, 5 or more. So this is what the group that got together for Duchenne's decided. Like I said, each society and many disease states have their own recommendations. What about oximetry? I'm not going to talk a lot about oximetry. I know Myrna gave a fantastic talk about oximetry, I think last year, with her work with Dr. Stroll. And but in brief, they can show you patterns. So you can have prominent variability in phasic REM of the sawtooth pattern. But you can also see sustained hypoxemia in non-REM, which might speak to reduced lung volumes, reduced FRC, or presence of hypoventilation. But it's not specific, right? So sleep, there are many causes of hypoxemia. It's hard to really tease out which one of those it is based on the nocturnal oximetry. And then you can have normal SATs in the presence of hypoventilation, so it won't necessarily distinguish between the two if the hypoventilation isn't severe that's causing hypoxemia. Here's just an example of a patient with right diaphragm paralysis. And what you see is at the beginning of the reporting, you're in the 90s, and then there's a sustained period of hypoxemia in the high 80s, and then you have the sawtooth pattern that lasts for an hour or two, and then again a sustained, back in the 90s, a sustained in the high 80s, and then sawtooth pattern. So, is this due to obstruction or pseudocentrals? Is this due to the sawtooth pattern? Is the sustained SpO2 due to low FRC? Is it due to supine position? There are a number of different causes. So you can see that it exists, but to say why with a degree of specificity, you can't necessarily obtain that from overnight oximetry. Now, what about in the sleep world? In 2005, there's a practice parameters for indications of PSG. And here it states for patients with neuromuscular disorders and sleep-related symptoms, polysomnography is routinely indicated to evaluate symptoms of sleep disorders that are not adequately diagnosed by obtaining a sleep history, assessing sleep hygiene, or reviewing sleep diaries. So similar to what the Duchenne's guidelines said, when to get a PSG. Of note, if you want to be able to assess the effectiveness of gas exchange of CO2, you're going to have to measure it. So that's either end-tidal CO2 or transcutaneous CO2. It's interesting. I've talked to some colleagues and they say they also get capillary gases. I haven't seen that in any guidelines, but that's practiced in some centers.
So that's so early for 2005.
Yeah.
It's all earlobes.
Right. Here is, this is from the journal, the Clinical Practice Guideline for Diagnostic Testing for Adult OSA, for Journal of Clinical Sleep Medicine. For the fellows, I'll point out that Dr. Auckley is an author on these guidelines. So just a reminder, take advantage of our faculty that's here. And so here it says, we recommend that PSG rather than home sleep apnea test be used for the diagnosis of OSA patients with significant cardiorespiratory disease, potential respiratory muscle weakness due to neuromuscular condition, awake hypoventilation, or suspicion of sleep-related hypoventilation, and so on. So you see here that, well, should we do in-lab PSG or a home sleep apnea test? The recommendation is, if someone has neuromuscular disease, to do it in lab as opposed to home sleep apnea test. Well, what are the limitations? So of an in-lab PSG. So first of all, it's expensive. Okay, it's expensive. That's not necessarily confined or exclusive to neuromuscular disease. It's labor intensive. It's not readily available in all centers. In Cleveland, we're blessed to have, a high-powered sleep city, but it's not the case everywhere. There can be long wait times. It's disruptive for families, and then monitoring may interfere with normal sleep, in particular limiting REM sleep, during which the sleep disorder breathing may manifest. So I had a patient with spinal muscular atrophy, a young girl, went to the sleep lab. Her initial test in the sleep lab, she's very uncomfortable, anxious, and she can fall asleep. So maybe we got like an hour of sleep, but it wasn't super helpful, right? The next subsequent nights, she was able to do it, and our techs do a fantastic job with children, especially complex children, but that's an issue. Sometimes they'll come to the sleep lab and you just won't get data because it's not the natural environment. So we talked about this CMS, so Centers for Medicare and Medicaid Services criteria, and this is really what many durable medical equipment companies use, these criteria. So in our patients, they have progressive neuromuscular disease. They'll have, and they need symptoms of sleep-associated hypoventilation. So you got to not document in your note, the patient has sleep-associated symptoms of sleep-associated hypoventilation, which include, concentration, morning headache, so on and so forth. They don't have COPD, which is not an issue in children, but can be an issue in adults. And then presence of one of the following on the right-hand column. So either an ABG with a PaCO2 above 45 while they're awake, on their usual FiO2, sleep oximetry with less time, 88%, SpO2 88% or below for 5 minutes or more, with the minimum of 2 hours of reporting time, and a MIP of less than 60 or FEC less than 50. And if you recall our multiple choice question, this is where it said is that the patient with Duchenne's, so they have progressive neuromuscular disease, he was having headaches, he had sleep-associated hyperventilation symptoms, and he had SpO2 of less than 88. And our example, that was for 10 minutes. So that's why he would qualify based on the CMS criteria. Now, in last year, and the three major societies, so CHEST, ATS, and AA, well, I guess four, American Association for Respiratory Care, ASM, and ATS got together to advocate to change the rules. And they put I recommend that you go through these papers. Dr. Patil was on the committee for a number of them. So this is one example of those papers, which advocates for optimal non-invasive Medicare access for patients with thoracic restrictive disorders. And table 3 in that paper says, lists of indications for initiation of BPAP, bi-level device. And it's any single criterion is sufficient to initiate BPAP device in thoracic restrictive disorders. So you hear they list 5 in subcategories. And so they have symptoms plus a vital capacity less than 80%. So clearly very different than the let's see, 50% that CMS has. Orthopnea, dyspnea, morning headache, daytime sleepiness, or unrefreshing sleep. That would be the symptoms, right? CO2 measurement, so above 45 on ABG while awake, or above 50 on end-tidal CO2 or VBG. 3 is sleep-related oxygen saturation from any source. Okay, so you don't need a PSG. This is what the group is advocating for, which is less than 90% for more than 5% of the night, or less 88% or less for 5 minutes. Vital capacity, whether it's forced vital capacity or slow vital capacity, right? Some patients can't do the forced maneuver, so they do a slow maneuver. They blow out slowly if they can't create a seal, and that they're advocating for less than 50%, and MIPS less than either 60 or SNF less than -40. So I don't know if Sushil, if you're available or not, but I don't know that this. I heard that this hasn't been. This was taken in front of whichever board considers this, and it was, I guess, delayed. The Medicare said we're not going to address it this year. So,
Continue
but
to be
you,
delayed.
oh, go ahead.
Yeah, continues to be delayed. Stay tuned.
Okay. So there is work being done to sort of advocate for our patients, but it's ongoing. All right. So we'll go to some classic PSG findings that you might see when you're reading sleep studies, or you might see in the report if you get back from a sleep study. And some of those are pseudocentral events, hypoventilation, obstructive sleep apnea, and then you can see chain stoke, periodic breathing if there's high loop gain or heart failure as well. And so what is a pseudocentral or diaphragmatic sleep disorder breathing? So that you'll see is sawtooth pattern of desaturations or dips. It occurs during phasic bursts of eye movement, so during REM sleep. The events are due to suppressed, right? So during REM, your intercostals are suppressed.
Neurologist.
Who wrote it?
Central.
Well,
Wait a second, it's generated by the brain to begin with.
well, so this is looked to be obviously, yes, but it looks so, you know, I think he recommends in this paper.
I understand.
Yeah.
Just if you inhibit the diaphragm, is that peripheral or is that central?
That's a great question that we'll have to meditate on. You have, so again, during REM, you have decreased intercostals. So your rib cage muscles, your external intercostals, when you inhale, are going to be less involved. And then you shift the burden to an already weak diaphragm. Now, it's an early sign of respiratory involvement. So here's an example. You have, okay, let's just do the, set you up for what you see, right? You have the EOGs, the eye leads, and then the chin leads, and then EEG, EKG, snore, left and right leg, nasal thermistor, airflow sensor, chest and abdomen respiratory rip belts, SpO2. And what you see here is that you have phasic bursts, so you have rapid eye movements. And then when you come down to the nasal transducer, you see a flattening of the nasal transducer flow. The airflow is flattened, but not 90%. So it's not an apnea. So this is a decrement in about more than 30%. So it's a hypopnea. You see that the chest has decreased. The chest excursion has decreased, and so has the abdomen, but the chest has decreased more. So this can be mistaken, if you weren't paying close attention, as a central. That's where people have coined the term pseudocentral, but really what you see here is that it's REM. There's less activity of the intercostals, so your chest wall is going to have less excursion, and then your abdomen, the diaphragm activity is less than usual during these phasic bursts, and so that is a sleep. It's pseudocentral. It's caused by diaphragm weakness in the setting of already the chest wall that's not working properly. And here you see that SpO2 goes down and comes back up with each one. Here's an example of an obstructive apnea in a patient with Charcot-Marie tooth. And so what you see here is that, again, this is CPAP, so it's actually bi-level, but you see they're on, this is the C-flow, chest, and then abdomen and SpO2. And what you see here is first the chest and abdomen are in phase, And then you see here, there starts to be a decrement of the flow, followed by the chest and abdomen start to get out of phase. Then there's an absence of flow, there's an apnea, and then there's an inversion of the chest rip belt. So the abdomen stays in phase, but there's an inversion of the rest of the chest rip belt. So you see here is that there's at least three different causes of thoraco-abdominal asynchrony. One of them is increased airway resistance. And so this looks like another one could be decreased compliance of the lungs, or people might say neuromuscular weakness. What they mean is increased compliance of the chest wall. And so, you have to figure out when you look at this, well, which one is that? And so you take all the evidence. Here you see the flow starts to decrease. The chest rip belt is inversion. You have a decrease in apnea, a decrease in flow. So that looks mostly like an obstructive apnea. This is something that's also very fascinating. You might see it. I've only seen it once in a patient with very severe myotonic dystrophy, but you can see this if you note, again, here's EKG, C-flow, chest and abdomen rip belts, and then SpO2. And what you note here is this is a 30-second epoch. And what you note here is that the patient's breathing 26 times in 30 seconds. That's fast or not fast? We'll take a poll. Fast, very good. So audience response thing. So why are they breathing so fast? So if you line it up, you see that it aligns the respiratory flow from the BiPAP aligns with the EKG, the QRS complex. You also notice, so here, and with each one of those, the machine gets triggered because it thinks it creates some flow, right? When the heart beats, it creates some flow. The machine thinks that flow going in is the patient trying to take a breath. It says, oh, you're trying to take a breath? I'll give you a breath. So, here 26 times in 30 seconds, you get a breath. Here, you'll notice the chest goes up a little bit. And so that's dynamic hyperinflation. For the pulmonologist, it leads to auto PEEP and then difficulty in triggering. So you don't see that trigger over here, but then when the chest goes down, it resumes autoballistic. So this is called cardioballistic triggering or auto triggering. You might see that term raised. Here's another example of the same thing. And clearly, right, this is a cardioballistic or auto triggering. For an auto triggering doesn't have to be due to cardioballistic, but it can be if it lines up with the QRS complex, and that led to overventilation, hyperventilation, right? And then which led to essential apnea. Glottic closure, this is a good one. So what you see here is a patient again on CPAP, the chest and abdomen belts. And what you see here is that the patient was triggering, right? They were breathing, their abdomen was going up, their chest was going up, the C-flow was being delivered. And then you have a time where these must be timed breaths, where the breaths are being delivered, even though, because the patient, it must be BiPAP ST, right? The patient hasn't breathed in a certain time interval that you've told the machine the patient has to breathe, so the breaths are being delivered, but there's no abdomen or chest rise. Well, why not? Breaths are being delivered, no abdomen or chest rise. So either you're not giving enough pressure and they're profoundly weak, but that's probably not the case because you see that you were delivering enough pressure in the previous breaths, or the airflow is not getting to where it's supposed to. It's not getting to the lungs, expanding the chest wall, and causing the diaphragm to go down, causing abdominal excursion. And that's glottic closure. So this is again from one of the 2010 non-invasive positive ventilation task force. They said attended non-invasive positive pressure ventilation titration PSG allows definitive identification of adequate level of ventilatory support for patients with neuromuscular disease who you plan using positive pressure ventilation. And you can, we talked a little bit about all these, you can troubleshoot as well in the lab. So in terms of what are your goals, patient comes to the lab, you get an email from either the nurse or the tech to clarify the goals of the study. Well, broadly speaking, you want to reduce sleep fragmentation. You want to sleep better at night, be well rested. Want to decrease the work of breathing and provide respiratory muscle rest. Normalize or improve gas exchange. Relieve or improve nocturnal symptoms if they have hypoventilation, and then confirm your, if you started the non-invasive ventilation empirically, then it's your opportunity to fine tune those settings.
Is that really what this guy thinks? I mean, it sounds like Aristotle.
This?
Yeah.
No,
I mean, the goal of getting them in the lab, see what they do, introduce them to the concept of non-invasive ventilation. That would be number one. Number two, and then the goals are this. If you told the technician the goal is to produce sleep fragmentation and improve sleep quality, what are they going to do?
Well, this is, yes,
I'm just saying,
in theory,
when the rubber hits the road for these people, write these things. That's the problem we have in the field. Got theoreticians sort of giving stuff, and give it to the tech, and the tech goes.
that's true. That's an important point. So I would,
I'm not, I mean, it's his point.
Yeah.
I mean, it's this listing, it's not yours.
yeah,
But, you know, for instance, when they call you up and they say, what is this all about? And you may have listed all that, they'll still call you up and say, what is this all about?
yes. So Dr. Stroll raises a good point in that when we give directions and, you know, my mentor, Dr. Carol Rosen would say the same thing, that the more specific you can be, you'll decrease, you know, you'll decrease the number of calls at night. So the more specific, so you have to understand how does a tech work, and you have to talk to your techs and know how they interpret things and what they're actually looking for on the front lines. So what does it mean, muscle rest? So decrease muscle rest. So here, what they did is they put an EMG of the diaphragm and abdomen. Here's a patient who's abdominal excursion. They're breathing spontaneously, and with each excursion of the diaphragm, you see a large activity on the EMG. These lines over here are EKG artifacts, so sort of ignore those, but pay attention more to bigger bursts. And then what you see here are non-invasive, and they're breathing faster, right? Rate of 18, so they might have shallow, rapid shallow breathing, or increased dead space to tidal volume ventilation. And then here you see here an adequate non-invasive ventilation, larger excursion, so you can extrapolate larger tidal volume. The rate has gone down. They have less dead space. So you can assume they have less dead space ventilation, and their EMG activity is decreased. On the EMG of the diaphragm is decreased compared to what it was during spontaneous breathing. So the theory is that you rest the diaphragm during the night. It has you decrease the CO2s during the night. You decrease that buffering of the central chemoreceptors. Then during the day, because you might ask, well, how does this affect them during the day? During the day, the diaphragm has more energy, has less, it's been doing less work during the night, and then the chemoreceptors are more sensitive. So if you think about it, what are the goals? From a sleep medicine perspective, you want to overcome the upper airway obstruction. We do that by setting EPAP. You got to make sure to pay attention to expiratory muscle weakness. If you have a patient that's profoundly weak and you increase the EPAP too high, they might interfere with their ability to exhale all the way. You want to improve ventilation and decrease rapid shallow breathing. To do that, you set the IPAP, right, to create your pressure support, or your delta P, your driving pressure. As we talked about, it has to do with the compliance. And then prevent respiratory muscle fatigue, as we showed. And then you can do by setting a backup rate for ventilation goal and diaphragm rest. I will say, so for ventilation goal, if they don't, you know, you can raise the pressure support to, you know, IPAP of 30, but let's say the leak is high, they're not tolerating it. Well, then what do? So then you can use your backup rate to help you, right? And so for our last minutes, I'll go through sort of the anatomy of the waveforms. So for a spontaneous mode, this is bi-level. You set an EPAP and an IPAP. There's no backup rate. Every breath is triggered by the patient's own breathing. They breathe in. That when this device senses a flow, inspiratory flow, which creates a little bit of a negative pressure that you see here, then it will rise from EPAP to IPAP, and then it will cycle off based on a parameter that you set. In most devices, it's a percentage of the peak flow. So let's say, for instance, the peak flow, just pick a number, easy numbers, 10 liters per minute. If you say I want to cycle off when it's 75% of that, so when the peak flow goes from 10 to 77.5, then the flow will go and switch to EPAP. If you say 50%, it's when it goes from 10, which is the peak, to 5 liters per minute, and then it'll switch to EPAP.
And that's physiologically, that's what. That's when you reach your compliance of your lungs and your chest wall.
Yeah.
Right? That's where the tips over.
Spontaneous or time, ST mode is spontaneous and time mode, so it has the abilities of the spontaneous mode, like you said, a spontaneous trigger, a spontaneous cycle. But if the patient doesn't breathe at the rate that you want it to, you set a backup rate, let's say 10. So if the patient has a backup rate of 10, every 6 seconds, if the patient hasn't breathed, the device will give them a breath. So that's called a device trigger or a time trigger. And those breaths, because the patient's not generating their own flow, the length that they last in IPAP is set by an I time, meaning you set it, you put in the settings, how long you want it to set, 1 second, 1.5 seconds, and so on. There's another mode, which is actually very helpful in some, at least in some children with neuromuscular, profound neuromuscular weakness, which is called pressure control, or in some, it's called assist control, pressure control. And this is, I think, the best of both worlds in the appropriate patient. So the patient's able to spontaneously trigger, but let's say they're too weak to really keep that flow that at a certain percentage of their peak flow. So they breathe in, it gives them a peak flow, but then they're so weak that they just drop right away. And so you're not going to get a very long breath. You're not going to get a very deep breath. So what do you do for those patients? So this is an option where they have enough to trigger, enough strength to trigger. So you allow them to spontaneously trigger, but then you support them. Every time they trigger, they'll get a breath, and that breath will last a certain time. Okay, that's for patients with like a diaphragmatic weakness, this can be helpful. And so it can either be spontaneously trigger or device trigger, but each breath, again, whether it's spontaneous or device trigger, will have a set I time. This distinguishes it between the ST, whereas ST and the spontaneous breaths, only the timed breaths had I time, and the spontaneous breaths were based on flow cycle. But here, each breath, whether it's spontaneous or device trigger, will have an I time. Well, how do you know? So you say, I'm not a pulmonologist, I'm a, whatever neurologist, I'm a psychiatrist, but I'm a sleep medicine, I'm a somnologist. So what do I do? How do I know like what rate my patients need? So there's a really nice table in that 2010 task force, which I love. And it sort of shows you based on the rate you have and how to pick up and the percentage of IPAP time, how long to set your I time to. And it tells you how to calculate it. It's real simple. It's really easy. And it also talks about IDE ratio, which is a little bit different than IPAP time. But in general, recommend setting the rate to the patient's spontaneous rate. In restrictive lung disease and neuromuscular disease, you want to pick closer to 40% IPAP time. Sometimes they need up to 50%. And then rise time, you want to set to patient comfort. And then like we talked about, you want to consider pressure control mode if there's premature cycle. I think we're out of time, so I'm not going to talk about VAPs, but we'll leave it with that. The last thing I'll just say is the very end is that if a patient is not triggering, you want to make sure to check for leak. The first thing you do is mask fit and leak check. Check for unintentional leak. If the leak is high, then the device doesn't know when the patient's breathing in and when they're breathing out. So all those settings that you did for flow, first triggering, meaning how to initiate a breath based on patient flow, or how to end a breath based on patient cycle, it's gonna be worthless because the machine doesn't sense anything. It's just gonna keep on increasing the flow to achieve the pressure. So step one, if your patient's having trouble triggering or they're having a synchrony, they're triggering or they're cycling too early, is to assess mask fit and unintentional flow. So in summary, sleep disorder breathing is common with patients with neuromuscular disease. You need a high index of suspicion to detect sleep disorder breathing. PSU is an important tool in diagnosis and treatment of respiratory muscle weakness and hypoventilation, and then titration studies to address both the upper airway obstruction, hypoventilation, and worker breathing. And common troubleshooting includes assessing mask fit and leak. So thank you, and I'll be happy to take any questions.